Hello everyone, this is Katie from Supercoder. Today we're going to take a couple of minutes to go over some questions we should be asking ourselves to help head off 2010 consult problems before they start. By now you've heard that starting January 1st, 2010, CMS is doing away with all inpatient consultation codes. Codes 99251 through 99255 and the outpatient consult codes 99241 through 99245. Are you prepared for the issues this may cause starting January 1st with the Medicare payer as well as your private payers as they decide whether or not to adopt Medicare's consultation code policy? You can fend off headaches before they start by getting answers to these three questions. Question number 1, do Medicaid and private payers have consult advice? You know this much from Medicare's new rules. If another physician sends a Medicare patient to your physician practice for consultation in 2010, you should now instead use regular EM codes like 99201 through 99215. But what about the other insurers? Medicaid and private payers may follow Medicare's lead, experts predict, but some payers may continue to accept consult codes. To complicate things, some payers don't even know about Medicare's new consultation rule yet, nor have some payers thought through whether they themselves will accept consultation codes in 2010. The lesson learned here is to pay close attention to private payer policies on consult codes. And rest assured, we'll be covering what the largest payers are doing on Supercoder, so you don't miss a trick in 2010. Moving on to question number 2. What happens if an admitting physician doesn't append modifier AI? Admitting physicians now have a new modifier to start appending for their initial inpatient service. As soon as January 1st hits, they must append modifier AI, which as the descriptor principal physician of record, to the initial visit code. This modifier AI will signal that the admitting physician is the physician who is overseeing the patient's care, as distinct from other physicians who may be furnishing specialty care, according to the CMS Transmittal 1875. You can find the CMS Transmittal 1875 on the CMS website, or if you don't like searching the CMS website, you can go to Supercoder and find a quick path to the transmittal from there. So how might the rules in CMS Transmittal 1875 apply to a real-life coding scenario? Well, let's see. Say an emergency room doctor sees a patient who was involved in a motor vehicle accident. He calls in a trauma surgeon because of possible intra-abdominal damage, and the trauma surgeon admits the patient because of possible bleeding. Let's say the patient is pregnant, so the OBGYN is called in and comes in for a consultation. In this scenario, the trauma surgeon would report a code from the 99221 to 99223 range with a modifier AI appended. The OBGYN in this scenario would bill a code from the 99221 through 99223 with no modifier. Here's where you need to watch out for problems. If the admitting physician does not include a modifier AI, then the payer is receiving two initial hospital care claims for the same patient on the same day. CMS Transmittal 1875 acknowledges that, saying, as a result of this change, multiple billings of initial hospital and nursing home visit codes could occur even in a single day. What is not clear from CMS is what to do when the admitting physician makes the mistake, and your physician, say the OBGYN in the above scenario, has submitted the claim correctly. Here's another concern. Suppose you're coding for an OBGYN who does a consultation in an observation setting. Your OBGYN will have to use an outpatient office code, but the new guidelines do not include observation codes 99217 through 99220, as requiring modifier AI to identify the admitting physician. Again, will this cause a concurrent care issue? If so, you better be prepared to fight for your claim. On top of that, will your private payers even accept modifier AI if they are the secondary payer? And this remains to be seen. Make sure you keep up with the consult coding developments in 2010 by networking with fellow coders. Finally, question 3 is here to consider as you try to cope with 2010's consult coding chaos. What about hospital inpatient levels? We know this much. Instead of consultation codes, CMS directs you to use initial hospital care codes, codes 99221 through 99223. But beyond that instruction from CMS, you have a problem. Consultation codes have 5 levels, whereas initial hospital care codes have only 3. Did you know the lowest initial hospital care code, 99221, requires a detailed history and detailed exam? Most physicians don't get their experts tell us. In other words, they don't have documentation of a detailed history and detailed exam to support 99221. So here's a physician documentation education action item for 2010 coders. In order to reach a detailed history, your physician must document an expanded HPI review of 2 to 9 systems and pertinent past social or family history. While this level of history is not difficult to document, the physician must document a detailed exam. In support of that level of exam, you must have an evidence of an extended exam of the affected system plus 2 to 7 related organ systems or body areas, if you are using the 1995 EM guidelines. If you're using the 1997 EM guidelines, in contrast, your physician must document 2 bulleted elements from 6 systems or at least 12 bulleted elements from the GU single system exam. Many physicians don't do this level examination at the time of the inpatient consultation because it may not be medically indicated. When you don't get to even this level, and you would have qualified for a level 1 or 2 initial hospital care code if it existed, your only option is to report a 99499, which has the descriptor Unlisted Evaluation and Management Service. The problem with this is that the claim will automatically go into review. One last final word of advice. As you seek out answers to these questions for your payers, be proactive and take action. You need to know the solutions to these issues to get your rightful reimbursement for 2010 claims that would have been consults in 2009 and before. Watch carrier bulletins. Find someone at the carrier who can clarify in writing how they want these services reported. Harass them for written answers and document those answers carefully in a master file at your office. And if you always want the latest, most up-to-date coding information and coding lookup tools, visit us at supercoder.com.